You're watching GTV, Cable Channel 70.
Over the next 15 years, the number of county residents age 65 and older will dramatically increase. In fact, senior population growth here will outstrip every other Maryland county. The experts say that as the population ages, it'll be necessary to retread the healthcare system. Even today, more than 40 cents of every healthcare dollar is spent on people in their senior years. Most older adults lead active, productive lives. They're blessed with good health and seldom need hospital care. Other seniors are susceptible to a variety of chronic conditions. These diseases, such as osteoporosis and heart disease, may have slow onset and be long in duration. Chronic conditions can be complicated with the involvement of multiple organs, and they're often accompanied by anxiety or depression. The majority of older adults want to age in place, to stay in their current home as long as possible. But the ability to ward off the nursing home may necessitate rethinking health care. Rather than a rigid service delivery system, the ability to age in place requires health care options that are flexible and provided as close to the home as possible. The home itself may need to be modified so that seniors don't need to radically change their lifestyles when their health changes. Many believe that the health care strategies needed for seniors are simply smarter ways to provide service. While they make it easier for older adults to live independently, these improvements can benefit residents of all ages. What are the health care needs of seniors living in the county? Does the current service delivery system need to adapt? And how might these changes affect you and your family? Hi, I'm Rich Krieg, host of On the Horizon, and with me in the studio today are Phyllis Medachi, Administrator, Howard County Office on Aging, Charlene Quinn from the Division of Gerontology, University of Maryland, and Kevin Carlson, a geriatrician in Howard County. Welcome to On the Horizon.
Thank you. Thank you.
Phyllis, let's start with you. The statistic is that in about 15 or 20 years, 1 in 5 Americans are going to be older adults. Are we in the midst of a geriatric revolution here?
We are. It's actually being called in some quarters a tsunami. Because what is happening is that baby boomers are reaching that age where every day this year 7,900 people will turn 60. And so what that's happening nationally and also locally, we have the fastest growing aging population in Maryland.
Do we know why? Do we know why we're growing so quickly in that area?
It's the impact of the baby boomers. This huge group of people is just moving through the demographic pipeline, if you will, and that's what's creating the aging projections throughout the year, or throughout the next 20 years. Another feature when you look at it locally is that baby boomers tend to attract older relatives to come and live with them. So when you begin to talk at the county level, you're talking about people who are aging as they live here, as well as attracting in their older relatives.
And I assume, Charlene, from the academic standpoint, that would indicate that people like the facilities here. That's why we're the fastest growing, perhaps, in Maryland.
You're right, Rich. People like to move where there is a good quality of life. We find older adults needing support as they age, so we see older adults beginning to plan with their families, as well as what the healthcare system has to offer. So the mobility of older adults has become something that's easier for people to do and accomplish. It does, of course, raise the question of do we have the facilities, the healthcare system to take care of older adults as this population changes?
Now let's jump on that question, Kevin, because you're in the front lines of that in a private medical office. First, tell us a little bit about your practice. Which practice is it? Where is it?
I'm part of Charter Internal Medicine, and we're in Columbia, right near Howard County General Hospital on Hickory Ridge Road. And we're a well-established practice. It's been practicing for about 15 to 20 years. I've been there for 8 years. I'm a geriatrician, but also an internal medicine specialist, and all the other doctors in the practice do treat people from 14 to 114 if we're lucky. And currently there are 4 other doctors in the practice.
Okay, well, you're a geriatrician. Let's start with that part of the workforce when we talk about the tsunami or sea change in the demography of this county.
Right.
How many geriatricians do we have in this county? You may not know the exact number, but
We have a handful of geriatricians by trade, not all of whom are board certified. That number is very small. I think in the country there are only 2,000 to 3,000 board certified geriatricians. And so it's unfortunate, but it's definitely not likely that most people will have a geriatrician as their primary care provider when they reach that age. However, most doctors are very well trained to deal with the needs of older adults and can do it satisfactorily. The geriatrician really specializes in the most complicated cases, the most frail elderly, those kinds of things, and can be a consultant for the primary care providers if they have any questions.
okay, well that geriatrician, Charlene, is in the vanguard. I mean, very, very advanced training, particularly board certification in the medical area. What's the full scope of the workforce? If you can just maybe characterize that for us.
It is important because there are obviously other disciplines, in addition to medicine, nursing, social work, rehabilitation therapists, dentists, etc., who are now recognizing the need to be able to better understand how to care for older adults. And it's interesting because the workforce issues in long-term care are probably the largest problem today. I heard an interesting comment a few weeks ago that if we took all of the graduates from schools of nursing and they applied to the open positions that are available in nursing homes, assisted living, working with older adults in the community, there would still be openings available. That's how drastic the need is. And in response a little bit to Phyllis's comment about a younger population, one of my interests is how can we encourage younger people to think about aging and gerontology as a career. If we are able to take 10% of the graduates from high school next year and encourage them to enter the field of healthcare and then specialize in aging, what a great accomplishment that would be towards the workforce
I'll
issue.
say, let's stick with this, Phyllis. Why don't you try to draw out maybe why is it that we have this gap between this growing population of older adults, but not enough people who are trained to do the various things that are required for that population?
I think there are a couple of reasons. In projects that we have done within the Office on Aging with high schools in Howard County, we have observed that kids are not often exposed to older people who are living in the community. They may know their grandmothers and grandfathers, that's the context, but when they are thinking about, gosh, what am I going to do in college or what I'm going to study, people often have the image that working with older adults is depressing and not exciting as a career. And so we have found that by exposing people, kids, to community dwelling older adults, we sometimes see greater interest in the fields that Charlene has been discussing, but also in fields that have to do perhaps with the kind of work that I do. I'm not a health professional, but people like me need to be well versed in what older adults need. So that's the first reason. I think it's exposure, and there's not a lot of it. The second is that often when people look at beyond professional fields, when they look at paraprofessional roles, those roles tend to be underpaid. And so it doesn't look like a potential career ladder for people. So funds, the way that we value who works, people who work with older adults, and exposure at a very young age.
Yeah. Kevin, you knew all of that, and yet you chose to become board certified in geriatrics. Why did you make that decision?
Well, I truly love the field of geriatrics. I felt like my older patients were my most rewarding patients to treat. They were my most medically challenging patients. They were also often my most appreciative patients. And I had wonderful relationships with all of my older relatives, and I knew that I enjoyed working with them and respect them greatly. And so I found that it was the kind of medicine I liked to do best. Mm-hmm. I didn't really think about the money, to be honest with you. I had no idea that financially it would make no difference whether I was a geriatrician or just an internist. I didn't really look at that, whereas I know a lot of other students do pay close attention to what the reward of their training might be. So maybe that wasn't as thought out as it might have been, but I have no regrets. It's an absolutely rewarding field.
Wonderful answer.
Rich, if I
Yes.
could follow up with both comments. At the University of Maryland, we have one of 6 doctoral programs in gerontology. You'd think there would be more. There's only 6. I'm currently reviewing applications for next year's students. The majority of the students who write as their professional goals will mention, I had a positive experience with a grandparent or with a family member, or even a positive experience working with somebody who had Alzheimer's. So I think that's the kind of thing, and as Phyllis said, a positive experience. And I think we need to educate the public, including our policymakers. We talk a lot about Medicare benefits and changes in those benefits. 80% of those benefits go to older persons living in the community. It's not for persons in the nursing homes and hospitals. And I think if we can sort of parallel education of the public and our policymakers about the real world of older adults, and that even if you are not going to be a board certified geriatrician or geriatric nurse, at some point your professional career you're going to be taking care of older persons or family members who have an older adult.
Right. Well, I'm glad you got us over to Medicare, because I do want to switch to the current service delivery system, and I think Medicare is one very big piece of it in being the major payer for hospital care. Phyllis, you now have within the many services of the Office on Aging, a project, a component that's called MAP, that is an information and referral system, but also, I think, has information like Medicare changes. Could you comment on that? Because that oftentimes is the first point of contact that someone might have with the delivery system.
And one of the hardest things is when you don't know something, figuring out where to go for that information. That's why we were eager to be part of a federal project that's called, at the federal level, an Aging and Disability Resource Center. It's a virtual center, and what it is a source of information for people over the age of 50 and younger adults with disabilities, and within those 2 age groups, people of any income. Because as Charlene was alluding to, it's not just access to services, it's planning ahead. So what we have done with Maryland Access Point, which is what Maryland calls this project, what we have done with Maryland Access Point is to use Medicare as an example. We used that staff to help the community figure out what plans they should be selecting when Medicare Part D came up in the fall, and we continue to work with the community on it because using Medicare Part D as an example, it's a confusing program. Planning ahead can be confusing, and so having a trusted and visible source of information, which we hope MAP is a good service to this community.
And I heard out of the corner of my ear, Kevin, that you kind of chuckled when Phyllis said it's complicated. Do you want to do some commentary on the Medicare changes?
Medicare D is becoming increasingly complicated. I agree MAP has been incredibly helpful, and I've been impressed at how well my patients have actually been able to navigate finding pharmacy plans for themselves. When the pamphlets came, I had them in my office and I would hand them to the patients and ask them to explain them to me after they read them because I really wasn't sure I had all the information correct. And we would chuckle about it. So it's extremely challenging for them to figure out which plan works for them and if any of them actually work for them or if they should even do it. So it's been a tough transition, and I think it will continue to be so.
And of course, what Medicare oftentimes grapples with is chronic disease, as opposed to an acute episode where someone's hospitalized. Cancer, diabetes, cardiovascular disease. Most of the deaths in this country, particularly for older adults, are attributable to that. Could you say a few words about maybe the differences with chronic disease? Many older adults will have 1, 2, 3, or more chronic conditions. So how does that affect the provision of services?
It's extremely complicated. For example, if you are diagnosed with hypertension, you're going to need to be on some kind of medication typically to control your blood pressure. And if you are diagnosed with high cholesterol, you may need an additional medication to control your cholesterol. If you have any signs of heart disease, it suddenly becomes 6 medications that have been approved and recognized by the American Heart Association to be the appropriate medicine for you to be on. You're jumping from 2 to 6. You add other diseases and other recommended therapies will ensue, and all of those will require prescriptions, following up with your physician, having frequent visits for laboratory tests and monitoring, making sure that you're making the appropriate lifestyle changes, helping patients get the support they need for those lifestyle changes, maybe referring them to the hospital for some physical therapy or rehabilitation for cardiac or pulmonary rehabilitation. And it's really becomes a complicated world that a lot of geriatric patients refer to as their new job, going to doctors and things.
Very complicated. And Charlene, that's just almost a prescription for disaster. You know, if you have all those prescriptions, for each one of them, you've got to know what the regimen is, let alone that there might be cross-action between these drugs. Is that a big problem in the state?
I think in terms of assisting older adults to manage their chronic diseases, I think not only the prescription aspect of it, but the connections between a primary care physician and all of the specialists. And I think that's what we're on the cutting edge of. How can we assist older adults and families to better communicate back and forth with the healthcare system? There are new technologies that are coming out such that instead of a physician saying, you know, when you go back to your cardiologist, ask them to check this particular medication. Instead, we will have specialists talking to primary care physicians and nurses, if they happen to be the care manager or social workers, on an ongoing basis. It's not there right now, but certainly electronic medical records, communications that are wireless between patients and physicians are on the cutting edge. Within the next 5 years, I think we'll see advances, and I hope that's what we can do to help older adults and their families manage their chronic diseases, because clearly we give them that message now. We say, if you have diabetes, if you exercise, if you test your blood, you will do better, and yet we don't give them the tools to assist them with that self-management.
Charlene Phyllis said cutting edge, and I was at a meeting recently, a couple of months back, where the head of the U.S. Department on Administration on Aging, Josefina Carbonell, said that Howard County is on the cutting edge when it comes to chronic disease management. Could you say a few words about what the Office on Aging is doing in this very important area?
We believe that the way to help people with multiple chronic conditions is to add a component to what Charlene just described, which is to add community supports in ways that the message that's heard through a physician is also reinforced in the community. And in order to do that, we have decided to adopt what is called evidence-based programming, which simply means that we're looking at the research that's done across the country that has a positive health impact on people with chronic conditions and translating that into the community. The latest example of that is last fall we ran a series of workshops for 55 people in 4 different locations that's based on work that was done at Stanford University in the around 1998, 1999. The research shows that the folks who went through this workshop learned better tools to manage multiple chronic conditions. It wasn't disease specific, but it was about goal setting and behavior change and incorporating things like exercise and changes to diet so that overall their daily living was better. Research also shows that those folks are going to have fewer days of hospitalization and less healthcare utilization. So by adopting research into the community, we believe that an Office on Aging can partner with the health community, and all of us can be working for healthy living.
And I think I heard somewhere along the line, and I know people go to Stanford from Howard County to get training. They become a master trainer, and I think I heard that when the information, when you've got support groups, comes from someone who has a chronic disease, they may understand less about the disease than, say, if a doctor told them, but their behavior changes more than if a nurse or doctor told them. Is that correct?
You're exactly right. The research has shown that when this message is delivered by, it's actually a team of people who also have chronic conditions, that the behavior change, they're modeling behavior change, which is different than Kevin telling me about my disease. I'm more likely to know more about my disease, but I may not be as likely to change my behavior. So this whole evidence-based model is about modeling and behavior change.
Now, Kevin, these types of conditions, relative to other types, are kind of preventable. A lot of them are preventable.
Absolutely.
Could you give examples of things that you think it's pretty easy to do, but that are very hard for your patients to do. Can you give some examples of that?
Absolutely. Well, the first thing is changing your diet. Anybody who's ever gained a few pounds at the holidays has tried to lose those pounds after the holidays, has made a resolution or two about making a dietary change, and they stick with it for a little while, and very quickly they go back to their old ways. So diet changes are very difficult to get people to stick with, and any kind of community supports that reinforces change is a wonderful asset to
And
have.
I think for those 3 examples I gave, obesity really does correlate with those 3
Obesity
diseases.
is underlying one of the biggest health problems we have in this country. I think it's along the tsunami size as the aging population, is the obesity population in all age groups. And it contributes to high blood pressure, high cholesterol, diabetes, peripheral vascular disease, almost every chronic illness, and of course arthritis and the discomfort that is often associated with old age. And that's one of my biggest pet peeves, is everyone saying it's all about old age when it's really not about old age. That's a stigma. It's about preventable things. So eating healthy, exercising, having balance in your life, good sleep, peace of mind are all equally important to going to the doctor and getting your pills. It's almost more important for those people to meet with Phyllis's group than it would be for them to see me once or twice a year. I think they would have an overall better, mortality and morbidity issues by taking better care of themselves. Not to say I wouldn't want them to come, but I'd be pleased if they'd made those changes.
That's a clarion call. I mean, it's very clear thinking, but hard to do in practice.
Yes.
Does the research, Charlene, give us any clues in terms of how to get to people to change their behavior? And some of these things are pretty simple, but very hard to do.
It is, and we, at the university, we are looking at a number of ways to evaluate how persons manage their diseases. Very much interested in self-care activities. We do an awful lot of education. Diabetes is a good example where we educate people about how to take care of their diabetes, but then we don't follow up and ask, how should we, are you able to do the self-care activities? I think the most important message that throughout our research that we look at, whether we're looking at diabetes, we do a number of research studies on hip fracture, prevention and management of the environment to prevent falls. It's around function, person staying active, no matter what stage of aging they happen to be in. And we can do these incredible studies, detailed studies, and the best message that we can give to our older adults is continue to stay active and proceed along those lines.
If you don't move it, you lose it.
Exactly.
And that example of falls, I heard a remarkable statistic a couple of months back that in the 65 and over population, 1 in 3 people every year will fall during the year. It may be a minor fall, but they fall. In this area, Phyllis, fall prevention, do you do anything with that? And talk, if you will, about the home setting in relation to fall prevention and other types of services that might be put there.
We have, as part of our office, what we call our Aging in Place program, and it consists of a combination of fall prevention intervention and home modification and repair. Because although the home environment is not the only reason why someone might be falling, it may be related to declining vision or multiple medications. By using occupational therapists on staff, this is back to function, which is what's so important. We can help people take a look at their home environment and not just look at is the hole in the roof need to be repaired, but what can we put into the home to reduce barriers, to make it safer. So handrails on both sides of the steps, better lighting, above and beyond, below the steps, things that you don't recognize when you live in your own home. Because sometimes it isn't the condition that creates the disability, it's the environment that creates the disability. So where we can keep people safe and reduce falls, that's really what we feel that is part of the office's mission in being proactive and helping this growing population in the county.
Should builders think of these so-called universal design standards when they build houses, no matter what the age of the future owner was?
It's a great question to bring up. A lot of times, things like a no-step entrance into a house or wide doorways are looked at as somehow you need this if you're older. The reality is that those are great features in a home and valuable to anybody, which is how the phrase universal design came up in the first place. So we would love it, many of us would love it in this community, if the homes that were built, regardless of the age of the initial buyer, were built with features so that they could work for anybody.
Charlene, just jumping from this, you mentioned a little ways back about policymakers and the need to have them really be aware of some of the facts, not that they don't, many of them do, but to really feel in their bones almost the sea change that's happening and what might be some policy shifts that could help older people to be healthy. What ideas do you have to do a better job on that with our policymakers?
With like policymakers?
Yes.
You know, it's interesting, Rich, I read an article just this past week of how scientists had spent, if you will, a basic research science program with the policymakers in Washington to talk to them about what is evidence-based medicine, so that it's not just something that they end up hearing it as a buzzword, but really taking them back and showing them. And I think we need to do some of the same things in terms of education about older adults and the environments that we need to create, and really have policymakers think, you know, beyond next year's budget, beyond next year's, well, if they could, next year's election. Where would we like our country to be in 5 years? And maybe begin with what's happening a little bit on the service side, which is culture change. That older people can continue to live where they'd like to live for as long as possible. But if they have to go to an assisted living facility or spend some time in a nursing home, that those environments as well will be as home-like as possible. And there are some companies, private companies, that are adopting culture change as part of their sort of mantra, but they see that as a way to address how our aging population wants to be in the next 5 years. I think that we do see our policymakers reacting somewhat towards looking at reimbursement for healthy aging. So for example, the fact that a few years ago they started paying for some of the preventive self-care activities for diabetes. That was a huge change for Medicare to do that. And I think we will hopefully see more of those kinds of policy changes down the road, both at the state level and at the federal level. It's important for us as researchers to constantly interpret our findings to policymakers, not just put it out as blanket science, but translate it into evidence, not just for the practitioners, but for the policymakers as well.
And although it was one comment, it was reassuring for me to hear the head of the federal office talk in glowing terms about Howard County. That shows that some people are getting the message about community-based interventions. We only have a little less than a minute left, and I think I'll give Kevin the last question. And I think I'll go back to the beginning when we talked about young people getting into this wonderful field of aging and all of its dimensions that we talked about. What would you say to a high school graduate here in Howard County who is thinking about a career and might be a little turned on by this program? What would you say to that young person about this field?
Call me.
Direct. Wow.
I really would. I'd be happy to mentor any young person who is interested in going into any healthcare field related to the elderly. It wouldn't even have to be a physician, anybody who wanted to go to medical school. But if they were interested in helping the elderly population, I would be delighted to talk to them. But I would encourage them to do it. There are many fields that will be very rewarding and very needed throughout their lifetime. It's not going to go away.
Well, on that wonderful note, I'd like to thank my guests, Kevin Carlson, Charlene Quinn, and Phyllis Medachi, for being here on the Horizon. Thanks for watching, and we'll see you next time.